আমি আছি।
ওকে, চলো তুমি ইয়ে করতে পারো, কৌশিক তুই অ্যাডমিট করতে পারিস এই লোক, ওয়েটিং রুমের লোকজনদের ঢোকাতে পারিস। আচ্ছা, আমার যদি চ্যাট নিতে কোনো প্রবলেম হয় তাহলে চাকি আর শঙ্কর একটু স্টেপ ইন করিস, ঠিক আছে?
Sure.
Right, can we start? 7 o'clock? Can we start? Host, Kaushik?
Just wait for 2 minutes. Few people are joining.
Sure.
Just wait for 2 minutes.
Okay.
আমি একটু জুম মিটিং আছে রে, পরে ফোন করে হচ্ছে। এই 8টা বলেছে, 8টা।
এ চলবে, লোকের যে রেটে লোকে আসছে তাতে মনে হচ্ছে হাজার হাজার প্রশ্ন হবে। ও আমার আলো জ্বালাইনি, দাঁড়াও, এই তো আলো। দেখি শুরু করি আমরা, লোকজন জয়েন করুক একটু একটু করে।
হ্যাঁ, স্টার্ট কর।
আচ্ছা, ওকে। Good evening, everybody. We will use a mixture of Bengali and English. If anybody has a problem, please let me know. So we have seen that the last few weeks, we knew that there was a new variant was discovered in South Africa. Remarkably, they have done a very excellent job, and they identified this new variant, which is the WHO within 24 hours declared it as a variant of concern. Now, what a variant of concern is that it has got a more infectivity and it can spread more easily. It has got more mortality and mortality figure as well. However, we didn't know much, but we knew that it was like a tsunami which engulfed whole of South Africa. In fact, it engulfed like 60 to 70% of the population. And South African medical associations and their health ministry have very nicely has kept us informed from time to time what was exactly happening, which is very different to the very first of the pandemic. So we are learning from each other. And we also came to know within the first few days, within the first 48 hours, that this variant is actually quite mild. Now, we have seen the devastation done by Delta in the second wave during the March, April, May, June this year. We all have seen it. We are all directly have seen it in front of our eyes, and we can never forget about it. The visuals, the mass funeral pyres, bodies floating in the rivers, we have seen it all. So obviously we are concerned. Here also from last Saturday, Friday, Saturday, the phones have started ringing again, and everybody is informing that amar hoyeche, er hoyeche, tar hoyeche, everybody. No household is left alone. Even in my household, my son, my mother got it. but we are experiencing quite mild symptoms. Mild means fever for a couple of days, but is it so, or are we only seeing what we are told to see? Now, there is media on the one side is scaremongering. There are scaremongers all over the social media, which has trying to frighten us. On the other hand, there are like, nothing is going to happen. It's a common flu. Don't take vaccine. There is quite a strong lobby of anti-vaxxers and anti-mask brigade, which are shooting into prominence. Especially after 2 lockdowns, in the 3rd lockdown, people are desperate and they will believe anything if that gives them a hope that this is nothing, you don't need to stay indoors. And slowly we are seeing that a very niche, a very small quantity of people who are saying the deniers, they are growing. So there is doomsday on one side, there is deniers on the other side, and we clinicians are stuck in between. Data is a huge casualty in this COVID. And especially our country, in our state, we are having an extremely difficult time getting a data. Exactly, because without data, we can't really assure or warn our patients what's going to happen. So that's we are seeing. So we are getting the, আমরা অনেকদিন ধরে প্রচুর অনুরোধ পাচ্ছিলাম সুমিত has done fantastic some previous evitas, which has been very successful. We used to get questions even a week after the shows are over. So Shumita has already told us about the alpha and the delta. He did too, and during the mucormycosis crisis as well. Now, due to popular demand, we present you Shumita. So Shumita, over to you.
Good evening. I hope I'm audible.
Yes,
is that
you are.
okay, audible? Yeah.
Yes, you are.
So here we go again. I mean, we thought after the end of the Delta, that was it, and we knew everything about everything. Unfortunately, it has turned out like this. Now, let's look at what is happening as compared to Delta. This is much more infectious. In fact, I feel, and I think I've looked through the literature, this is the most infectious.
I will just interrupt you for a minute, Shumita. For everybody, we will keep it very informal. Chat, and Shumita is also going to talk informally. So please don't expect a proper PowerPoint and with animation presentation. But you will get the hard facts, and we will have a heart-to-heart talk. I can assure you that.
Okay. So the issue here is that we all have, in our own ways as doctors faced with COVID for the last couple of years, all of us are specialists in our own way. You have to be a specialist, you have to do the same thing over and over again with a little bit of intelligence and insight. Now, this variant, which we read about in the papers, we looked at the literature from South Africa, as Arjun has said, but also in the UK, it spread like wildfire from one to the other and it's taken over. So there is no doubt that this is very infectious. In fact, according to some authors, this is the most infectious disease known to mankind ever, recorded history. So that being the case, we are now faced with practicalities of not just theorizing about what it is, but what do we do? Essentially, that's the question. What do we do about it? So let's look at the first basic steps. That, okay, so any viral disease, as we know, Delta and everything, we wanted vaccines. So we've got the vaccines. How well do our vaccines in Kolkata or in India measure against Omicron? Well, the data is pretty strong. The only place in the world which has used 2 doses of AstraZeneca vaccine is the UK, and they have fantastic data. We have no data from India about what happens, but we will extrapolate from UK. Basically, 2 doses of AstraZeneca vaccine 6 months after the second dose does not prevent any Omicron. That's the data. However, even if Omicron is not prevented, 52% of severe disease with Omicron is prevented. So if you're fully vaccinated, then your chances of having severe disease is half of what it would be if you weren't vaccinated. So what about boosters? As you can see, the Western societies have all given open carte blanche to boosters for everybody. We haven't. I am not very sure what is the reason behind this. It seems very apparent to me that we need boosters. The evidence is strong for 2 Astras followed by Moderna or Pfizer vaccine, very strong. If you take 2 followed by mRNA vaccine, 2 Astras followed by mRNA vaccine, prevention of severe disease is to the tune of 90%, and prevention of infection is 60%, which is very good. We do not have Pfizer in India. Again, I do not know the reason for that. There is no scientific reason for it. So what do we have? We have a 3rd dose of AstraZeneca. Now, because only India and UK have been using 2 AstraZenecas, the question of the booster only arises from data from these 2 countries. We in India have no data. In the UK, unfortunately, they are not giving a 3rd AstraZeneca dose. They're giving a Pfizer dose to people who have had AstraZeneca. And there's fantastic evidence, as I just told you, that a 3rd dose will prevent severe disease. Extrapolating from lab studies, immunogenicity studies, AstraZeneca 3rd dose booster is not as good as a Pfizer booster, but it is pretty good. Its prevention of severe disease is to the tune of 82% predicted. Okay, so we need the boosters, everybody. So from 10th of January, please, all of you as doctors, line up to take the boosters if you haven't already managed to get it. There is no question that we need it. Coming back to how bad or how severe this disease is, Arjun has mentioned this is much less severe. That is absolutely true. I think this is at least 10 times less severe than Delta. Let me tease out what I exactly mean. It's not like that you get it, it will be 110, the fever will be 110. That's not like that. So you have a proportion of patients who get infection. That will be huge for Omicron, as you can see yourselves. Of these patients, much smaller, 10 times less, maybe let's put it in figures which are ballpark, 1% will be severe enough to reach hospital for Delta, and 0.1% would be severe enough to reach hospital for Omicron, for pure COVID. I'm talking about pure COVID. Now, so that's brilliant, isn't it? I mean, it's 1/10 the chance of you getting to hospital. Unfortunately, this is a linear equation. Now, the exponential equation is the spread. So let me say each Delta patient infects 2 more, and it's got 1% mortality. I'm just giving the figures as a ballpark. And each Omicron patient infects 4 others, and its mortality is 0.1%. You think which is better? Well, actually, if you calculate after 10 levels of spreading, 1 Delta patient will infect approximately 1,000 patients and 10 will die. And for the Omicron, 1 Omicron patient will infect more than 1 million patients and 1,000 will die. So the infectivity is exponential. The mortality is linearly about 1/10. These are all approximations. So I just wanted to, present to you that less severe but more infectious is not necessarily the best of things. There is another aspect to Omicron which we are finding out, and it's there in the experience of countries before us. Now, say in the population, 30% of the people have Omicron at any point of time because it's very infectious. And but in the general population, you have people who come in with acute myocardial infarction. 30% of them will be Omicron positive, not because of the Omicron, but just statistically, the probability is all your MIs, all your AFs, all your heart failures, all your strokes, all your appendectomies, all your acute abdomens, a significant chunk will be Omicron positive. Maybe the virus is not affecting the disease, but they will be in the COVID wards. So that statistically in UK varies from area to area, almost between 40 to 50% of Omicron or COVID admissions currently are what we are calling now incidental COVID. So they are coming in for a separate indication, which is anyway would require them to be hospitalized, but they have COVID. That puts pressure, a huge amount of pressure on the COVID teams. We cannot get the casualness of a cardiac, a cardiologist seeing a patient on COVID team as we were doing before. So what is the situation in Bengal or in Kolkata? Last Friday, today is Sunday, so that's about 10 days ago, it was obvious. I was getting exponential phone calls and messages, which had stopped for the last 6-8 months. And I realized that we had Omicron. This is not Delta. This is not what we'd seen before. So I called up various senior people in the School of Tropical Medicine. And I wanted to know very specifically one question: what proportion of patients were they getting as Omicron? Because our clinical, let's say strong suspicion was that it was all Omicron. And I was told after people checked out and came back that not a single community sample from West Bengal is being tested for Omicron. I repeat, not a single sample from West Bengal is being tested for Omicron. Only tests they are doing are international arrivals. And I thought Friday, okay, they might, and the official reason giving is reagent shortage. Now, I thought, okay, it's Friday, maybe Saturday, Sunday, Monday. So if you see from the data which is given in the newspaper, that's the only source of data we have at the moment. For the last 8 days, West Bengal has the same number of Omicron patients, 20, right? So what I heard is what is coming out. So do not believe the government statistics about Omicron. We have to go by our clinical suspicion, and our clinical, I won't say suspicion, almost certainty is that all these patients are Omicron, all of them. So why is it important for us to understand? We can see that it's most infectious if it's Delta or Delta. Three reasons. We have to plan for non-COVID related treatment on the wards. And we have to also think about this numbers we spoke about. So over next 4 weeks, the huge number of community Omicron patients means that there will be an increase in COVID coming into ICU. Pure COVID, not incidental COVID. Incidental COVID, there'll be a huge rise as well. Let's go back to what do we know about the treatment for Omicron? What are the new treatments available? The reason I wanted to know about what proportion of patients had Omicron is that the monoclonal antibody Ronapreve available in Calcutta and India does not work against Omicron. This is a Roche, the maker's website has categorically stated so. So we need to know that should we give this? We were using it in vulnerable patients in the first 7 days of illness. So the answer is you should counsel the patients and say it is Omicron, it's unlikely to work. Some people might say that in the first 7 days, we don't mind, just give us the antibodies. You need to tell them that it's extremely unlikely to work. The cost is about 1.2 lakhs, so it's not a joke. So Bandor monoclonal antibodies should not be prescribed. It's very clear. Again, we can't be 100%, therefore we will have to let the patient decide ultimately what they want to do. Secondly, there are antivirals. One is available in Calcutta. There's another one which is apparently much better, which is in the offing, which will take a couple of months to come, I'm told. So one is Molnupiravir and the other is Paxlovid. I will not talk much about Paxlovid except to say the data is very promising and it's probably 2 or 3 times more efficacious than Molnupiravir. Molnupiravir, does it work against Omicron? Lab tests and scientific analysis suggest that it does. So you give it in the first 5 days since symptoms to prevent by a factor of 1/3, 30%, the chances of getting hospitalized at day 7 or 8. So that's what it does do. It has criteria for use, which includes age variably 60 to 65 or above, and risk factors, diabetes being the most important, obesity, as well as any immunosuppressive disease, drug, or condition. So it can be used. It has contraindications as well. You cannot give it to pregnancy or lactating mothers, and contraception has to be advised 9 days for women and 3 months for men after using this. But given its profile of indications, you will not be prescribing it to any sexually active patients, or it will be very rare. In which case, if you do, then you should do that. Apart from molnupiravir and the monoclonals, there is a specific monoclonal, which is sotrovimab, which is a GSK, GlaxoSmithKline product, which is available in America now and in the UK, which has specific activity against Omicron. Unfortunately, it has not been marketed yet in India. We don't know how long it's going to do it. GSK does have a presence in India, so one would hope that it will be available. I have no idea about the cost. Apart from this molnupiravir and the symptomatic treatment of paracetamol and steam inhalation and all sorts of things like that, nothing else is indicated in the first 7 days of illness for Omicron. It is by far a much less severe. It is like a common cold, a flu-like illness. You get stuffy nose, irritating throat. Some people get high fevers, occasionally get diarrhea. I haven't heard a single patient complain about nasal lack of smell. You do not need to do anything else. No doxycycline, no azithromycin, no ivermectin, no vitamin C, D, nothing. All these have been debunked as treatment of COVID. And the problem will lie again with the elderly and comorbid, and usually both, the elderly with comorbids. To give our experience, we've had 7 people who have required more than nasal oxygen over the last week. One of them yesterday, the first patient in this wave, was intubated. Others, 2 of them are improving slightly on high flow nasal oxygen and BiPAP. And the others have just settled down quite nicely. So as expected, despite the numbers, the severity is less. However, it's early days, and over the next 2-3 weeks, we will see other people. I lost a personal friend early this morning who was 62 on rheumatoid arthritis treatment, who died, ventilated and died in Command Hospital. So it will kill people, it will kill vulnerable people. So you need to be very careful about what you are advising. Now, what about treatment once in hospital? There is strong evidence to suggest there is no difference in progression or treatment between Delta and Omicron once you are in hospital. From the point of view of support is oxygen, 6 liters, up to 6 liters per minute nasal cannula. Then you go up to CPAP, which is now preferred over HFNO. And then if you fail, you intubate, ventilate the patient. In centers which have good availability of ECMO, there's a certain criteria to be fulfilled, you can go to ECMO. For treatment, it's steroids, dexamethasone, and we are using baricitinib rather than tocilizumab. You cannot use both together. Either or should be given in progressively hypoxic patient, along with Clexane anticoagulation, not oral anticoagulants. There is proof now that oral anticoagulants in hospitalized patients are inferior to low molecular weight heparins or heparins. A word about anticoagulants in the community before patients get severe. There is good evidence. There is no benefit in the first 7 days of illness to give any anticoagulants. In fact, the strong recommendation is you do not do any test unless it's related to comorbidities. No CTs, no blood tests, unless you have a patient with renal failure or diabetes or something like that. It does not impact the management of the patient. So coming back to hospital management, so you have oxygen, respiratory support, steroids, you have low molecular weight heparins, and you have either baricitinib or tocilizumab for progressively hypoxic patients. That's the same as what we were doing with Delta. There is one thing which we were doing with Delta, who were till recently, is some of these patients are unvaccinated and some are immunocompromised when they're coming in. So we were sending COVID antibody. You know, the recovery trial, one big trial in the UK has shown, if your antibody levels are low because you're either unvaccinated or your vaccine hasn't taken, as it were, then you can give a higher dose of monoclonal antibodies, Ronapreve, if the patient is hypoxic, only if it is low. But we are not sure whether that holds for Omicron. It is likely it doesn't. Again, in the absence of data, we are not tending to treat patients with that because of the uncertainty of its activity against Omicron. As for antibiotics, in the community, no antibiotics unless there is strong suspicion of community-acquired pneumonia. As for incidental COVID, you have to be very careful what you are doing. I will give you two examples. Both of them, neurological patients, multiple infarcts, Parkinson's, elderly, almost bedbound at home. Both of them came in with hypoxia. Both of them on admission were COVID positive. You see, these patients, they do not give you a history of symptom onset date. We managed to get a CT on one of them. The other one, we didn't have a CT. Both of them were intubated. I don't include them in the COVID statistics because it is fairly apparent that this is an incidental COVID. These are the patients you see in ICUs anyway, even before COVID, and we'll see them after COVID. Elderly, bedbound, neurological disease, aspirating and getting pneumonia. And here, the tendency to give steroids, baricitinib, is sometimes it is COVID, patient is hypoxic, routinely we are giving. We shouldn't do that because steroids and baricitinib are immunosuppressive. And these patients already are immunocompromised given their age, immunosenescence and everything. So one should like to quantify in this case how much hypoxia is due to COVID and how much is due to a bronchopneumonia, which we are familiar with. It's a difficult decision. A CT would help, but sometimes it's not too difficult. The one we got the CT on had multiple centrilobular consolidations, classical of bronchopneumonia, aspiration. There was no ground glass in the periphery, and we did not give him steroids or anything at all. So hospital treatment till date remains the same. The prognosis of patients who require hospitalization is no better than Delta. The numbers of patients who are coming into hospital are much, much, much less than what you would expect from Delta. However, the absolute number of patients will go up over the next few weeks, and then we will find out where exactly this will stop. I think I'll stop here, and I'll give a chance to Arjun to focus on issues, things which I haven't covered. Arjun, over.
Okay, it's only first, I won't say in a week, just first week into the Omicron surge. So what we have learned from Dr. Sumit Sengupta and what we know today is we are seeing a surge, absolutely deluge of Omicron patients. However, in paper, it is still 20 Omicron cases in West Bengal, which is absolutely ludicrous. And when we are denied data, this is what happens. Problem happens. We know that once it is severe, it acts the same as Delta. Now, I will ask you specifically two things, Shumita. From the South Africa experience and from the American and the UK, where there is already we have seen it surge, how long do you think it will going to last in India?
Well, it is difficult because of the different levels of vaccination and background infection to extrapolate. Let me say, I have colleagues and friends from medical college who are in USA or UK dealing with COVID, and we have a very good network with them. The news from the USA is that almost 95% of their ICU stroke ventilated patients are unvaccinated. So for the unvaccinated, this is going to be huge, right? And from the UK is a similar story. They have a lot more sort of incidental COVID. But the number of cases going up in India or in Calcutta, as far as we can see, is mirroring more South Africa than UK and USA, proportionally. And There are similarities. South African median age is about 40, so is India. We had a lot of community infections which were undiagnosed and was found by serology. So we've got a background infection rate which is much higher than the Western countries, and our vaccination rates are not too good. So if you take South Africa, it would be over by the end of February, if that is the way things go here. If you take USA, it will take much longer, and it's going to be somewhere in between, because South Africa is a small country, so it's geographically localized. Whatever you say, it's geography. But USA, like India, is a huge country, so you'll have pockets where there's going to be an upsurge and go away, and then it'll settle in that pocket. But then you'll have the next pocket somewhere else, 500 kilometers away, and the Indian sort of thing will be kept ticking over. And as you have seen, that anybody who gets Omicron, the whole family is infected. This is very, very, very stark sort of thing which we are seeing now. And that suggests in a reverse way that masks work, because the only place we are consistently unmasked is at home. So if one person at home gets it, everybody gets it. And I have seen over 3,000 patients, including in the last week, over say 50, 60 Omicron in hospital. I still haven't been infected. I'm not sort of saying that that's something very great, but the reason is that I'm seeing Omicron patients only in hospital when I'm masked. So please use the mask. It works. Whether N95 is better than surgical, it really doesn't matter. It's when you take it off, that's when you're at risk. And for my point of view, I am highest at risk in my clinic, actually, because I'm sitting in a small room with this air conditioned, and people are coming in every day, 2 or 3, saying, "Oh, আমার তো সর্দি কাশি জ্বর হয়েছে 3 দিন ধরে, বলে আর কোভিড টেস্ট, বলে কোভিড করতে হবে ডাক্তার বাবু, আপনাকে তো দেখাতে এলাম, আপনি বললে করাবো." So this is the story. And you sort of look at them with aghast and say, "Please go and get the test." So I think the feedback we are getting is masking works, but if you are unmasked in the presence of somebody within 6 feet, you are going to get Omicron. It is almost 100% certainty. So be careful when you take your mask off.
Shobita, another question. The South Africa was the first country, and we have seen already that it's more or less coming to an end over there. And the death rate from Delta, they had about 110,000 deaths from Delta. I mean, previous Alpha, I'm not taking them into consideration. And they have reported 10,000 deaths from Omicron. So in view of these figures, do you see light at the end of the tunnel?
As I said, I mean, we cannot extrapolate one country to the other. But yes, I think we in some ways, we are more like South Africa rather than USA and the UK. We have much less elder people, and we've had a much higher rate of community infection. The actual figures from South Africa is, if you're hospitalized, you have 1 in 4 chance of dying as compared to Delta. So in hospital Delta versus in hospital Omicron, they say 25% less chance of dying. So that is also quite a substantial decrease. And I would hope that it's like South Africa, let's put it this way, but can't be very sure that this is what's going to happen. We are a much bigger country, so it's a little bits of that keeping on, one of the fires will keep burning while the other goes out. That sort of thing might happen.
I'm starting to take question from which is putting in the chat box. So Professor Pranab Kumar Bhattacharya has said that the same Covishield vaccination as a third dose will not help much to increase the neutralizing titer, but will help to simulate the CD8 cells, which help in killing the virus. It's better to give the third dose vaccine with other vaccine.
Absolutely, I agree. That's what I said, that 2 doses of AstraZeneca vaccine is almost zero protection against infection. However, 2 doses still decreases your chance of getting severe disease by 50%. The third dose, what it will do is unclear, because nobody in the world is using a third dose except in India. And from immunogenicity studies, it suggests that the protection against severe disease will go up substantially, but we don't know how much. So the third dose is absolutely essential. In fact, we should have added it beginning of December rather than now.
Absolutely. He also added that in India, New Delhi, about 70 to 79% Omicron is probably the same is true in West Bengal. I mean, we have discussed that. Yes, 20 cases of Omicron is absolutely ludicrous. He also said the cocktail antibody doesn't work either in Delta or Omicron as per as the published work in journal Nature.
That is not really accurate. It works very well against Delta. The whole trials were with Delta, with some of them. It doesn't work against Omicron.
Dr. Niladri S. Dingle has mentioned what we are a lot of getting in, mostly in WhatsApp, is what about the mutagenicity of molnupiravir? Is it safe to use?
Well, you're not going to give it to anybody who is in the sexually reproductive group unless there is a severe chance of disease. So yes, just follow the instructions. It's very clear. Don't give it to pregnant or lactating patients. And for women, advise contraception for 9 days, for males for 3 months. Should you be giving it to somebody below 45? Which I really don't see any reason to do that unless they've got something severe like leukemia, or they are very badly diabetic, or they have some other, maybe a transplant patient. Yeah, so those are the people I would give it to. Otherwise, it's really not of concern.
Okay. Devdeep Dasgupta has said, do we need to do the routine blood test, that is CRP, D-dimer, in patients who are in home isolation or elderly with mild symptoms? Any indication of HRCT test?
I am not advising any tests to my patients. I did not advise them even in Delta, because none of these tests are actionable, right? You would only do it for comorbidities, or if you suspect another complication like a bacterial pneumonia or an MI, or renal failure or something like that. I have not yet come across any blood test or chest CT which has made me change my treatment. And the literature in the UK, in the USA also suggests in the first week it is not really useful in sorting things out for pure COVID, because whatever you do on day 3 is going to change by day 8. Either it will get better for most people, or it will get worse for the ones who get better. So I am not advising at all any tests in the first week, unless there's some query. I mean, you're not sure it's COVID. Maybe there's dengue. Maybe you think you want to do MP for MP dual antigen for malaria, or you think is a MI or a bacterial pneumonia or a UTI, whatever, sugar control. But I am not advising any blood test or CT scan in the first week.
Shomadri Sengupta has written a very long question, but it's got very personal information. So we are not going to discuss it in here because it will be against both Shumidda and Shomadri's issue. Kaushik, can you just copy paste the question to Shumidda separately so Shumidda can directly get in touch with Shomadri? Shomadri, if you can just leave your number to any of us, we will get Shumidda to get back to you. Sanjay Homchanduri said that please suggest medicine for patient having persistent dry cough after 10 days. We presume it's COVID.
Well, I don't know if it's going to be Omicron. You still haven't had 10 days of Omicron yet. So I don't know the answer to that. For Delta, I would not give anything. It will get better. If you really want to, I think frequent steam inhalation is the only thing I would prescribe.
Best thing.
Works
brilliantly.
And I am a little bit against cough suppressants because they don't really work very well, and if they do, they have too many side effects. So I'm not very keen on that. But it's you need to individualize, I suppose.
I think we can safely say that steam inhalation is the best thing. And if the saturations gets affected, get admitted. Dolan Chapa Dasgupta has asked that, sir, how likely the peak of infection in West Bengal will be flattened? I think we asked this question. Shumidda once again, want to help it?
These are what we call fundamental, or বাংলায় বলে মৌলিক প্রশ্ন। ইউনিভার্সের শেষ কোথায়, ভগবান আছেন কিনা, আর কবে পবিত্র শেষ হবে, বলা খুব মুশকিল।
তো হবে সুবিধা ভগবানের ফান্ডামেন্টাল জ্ঞান আসার আগে আমাদের বলে দিয়েছে যে হি ইজ লুকিং ফর এন্ড অফ ফেব্রুয়ারি। I think we all, lot of us will agree to that. At the end of February, probably we'll see the end of it. Sir, is the same question, Sandeep Tripathi, sir, next week mein kya badega or COVID is going to go up next week? I think I can answer that, Sandeep. Yes, it will. It's going to skyrocket next week.
The statistically speaking, if this is Omicron, which it is probably, it's doubling every 3 days. So yesterday was 16,000. So you do the math yourself. So 3 days down the line, it will be 32,000. 3 days down the line, it will be 64,000. So in 1 week, it will be 64,000 cases per day we are talking about. And once the population who are at risk are finished, then only will this stop. So that's what I'm saying. This is probably the most infectious disease known to mankind.
Ever. And with that, Gangasagar Mela is going to help us a lot.
Yes,
and with the election campaigns. I mean,
I will not
what a joke.
be politically incorrect about this, but I have
Yeah,
seen
we can
meme.
be. Yeah, we are not. We are known to be a
I've
controversial.
seen a meme, Jatayu next Upanyash, ওটা বোধহয় নিশ্চয়ই সবাই দেখেছেন, গঙ্গাসাগরে গঙ্গা প্রাপ্তি.
Absolutely. We doctors can say whatever we want.
So I think it's ridiculous. Absolutely
ridiculous. Even the court agreeing to it. Dr. Niladri S. Dingal, when to get a booster dose after recent COVID infection? Yes, that's a question a lot of people are asking. A lot of people, booster dose was due this 10th to start. They're starting to get SMSs. And suddenly some of them have got COVID. So how long should they wait?
This I will answer. I'm extrapolating from Delta. AstraZeneca vaccine advice, as I said, I follow the UK because they are the only people who have really scientifically gone after it. So they advise after a COVID infection, give 1 month from the symptom onset and then give any dose, a first dose, a second dose, or a booster. So I think you should follow that. Now, the government of India said 3 months after COVID, that is not a medical advice. That is an operational advice because they had not enough vaccines. There is no point in waiting for any more than 4 weeks. However, there is a chance that the Novavax vaccine, which is actually a protein conjugate vaccine nanoparticle, which is being manufactured by the Serum Institute, it is being authorized in India, that may come through. Personally speaking, if I get a opportunity, I will wait for that vaccine. But updates are not available. The immunogenicity studies suggest that it will be better than Covishield for a third booster if it is available in India. Again, Moderna has been licensed, but it's not available. Pfizer, as I said, it's the best possible booster, but it's not available.
The availability of vaccine in India is getting into a joke. I think total about 6 vaccines are commissioned in India, while there is about 115 vaccines have been developed, which is funny. I mean, like, if you're a free country, then all the vaccines should be available. I mean, which one government gives is a different issue, but the vaccines should be available to people. Anyway, Shubhajit Das said that most of the physicians are getting affected. Yes, I agree. My colleague got affected this morning. Given the huge number of mutations in the Omicron variant, does it offer any additional immunity?
Again, it's too early to talk about that, but there is a small paper which is a preprint which suggests that post-Omicron 14 days, the neutralizing capacity is very high in the patients they studied, and it neutralized everything right up to Omicron, including Delta and Alpha and all the other variants. So I'm sure there'll be much better data coming up, but the answer is probably yes.
Rajiv Roy has said, good evening, my family is affected, fever is subsiding, but throat is still sore and cough cold. When do we do RT-PCR, each HSCT thorax required? I will answer the first question. If you haven't already done a rat test or RT-PCR, do it now. If you have already done it and they are positive, you don't need to repeat it. If they're mild or moderate symptomatic, treated at home, then from the day of the start of the symptoms or the day of the test, if they're asymptomatic, you isolate yourself for 7 days. At the end of the 7 days, you will be, provided that the last 3 days you are aparaxial, you don't have a fever, and you don't need to repeat any test after 7 days. If the patient is hospitalized, then it's up to the clinicians to do. HSCT thorax, can I ask for you, talked about you, Shumita, unless the patient is not hospitalized, there is no point of doing an HSCT thorax. Isn't it right, Shumita?
Absolutely, unless you suspect something else going on. We have had ILD patients come in, or something which is funny. So that will be a clinical decision. But for COVID, you don't need HRCT as an outpatient.
Okay,
just don't.
Anirban Pal says that when to start steroids and in which patients?
Right. The answer is the same as what you should have been doing before. I don't know if you were doing it. Anybody with hypoxia, usually post 7 days of onset of symptoms, defined as saturation less than 94 persistently. There is a controversy about that. WHO says saturation less than 90 persistently. But however, we would accept 93 or below persistently, not just somebody has looked and 1 second it was 91 and then it was 100 after that, not like that, because that has been a big problem of asthma. And at the doses which are prescribed, which is 6 milligram dexamethasone or equivalent. There is some small evidence in hospital patients who are more severe. A higher dose of steroids might help, but that is very, very specialist, and I would not recommend giving. I would not recommend at the moment giving anybody steroids as an outpatient. If the patient needs steroids, he's hypoxic, he needs to be in hospital. It's simple. We still have the beds. We still have the beds.
Kanchan Mukherjee from Sumida's Medical College is being cheeky. He is asking, আমি শুনলাম Omicron গলায় আটকে যাচ্ছে, ফুসফুসে যাচ্ছে না। HRCT করতে হচ্ছে না। ফুসফুস স্পেশালিস্টকে জিজ্ঞেস করছি, is it true? Sumita,
no, that's not true. That's not true. But the proportion of patients getting lung, as I said, is much less than what we've seen before.
Shubhajit Das says again, the role of steam inhalation, role of gargling, is there any scientific evidence?
There is, but not a lot. So I think it's what I tell my patients is it's symptomatic treatment. If you feel better after taking it, please continue to use so. It does not alter the course of the illness. If you're not feeling up to it, then don't use it if it doesn't help you. And one of the major things you need to be very careful about, if you get too hot steam, it actually irritates you more and makes you cough more. It has to be just right, and it should soothe your throat and your thing. Otherwise, it makes better. There is not a lot of good scientific evidence, but there are some papers looking at steam inhalation.
Shankana Jha has asked indication of antivirals.
Antivirals now, we are giving molnupiravir to people with risk factors, which is variably defined, but more or less 60 plus, with or without diabetes and obesity. These are the three main risk factors in our opinion: age, diabetes, obesity. Obviously, any immunosuppressive disease, drug, or any disorder which causes immunosuppression, I think I would give it to all my transplant patients who I deal with. I would also give it to anybody receiving chemotherapy within the last month, which means ongoing current chemotherapy. Doesn't have to be current in the, like he's not having it tonight. So these are the groups we give it. Below 45, there is very little, scope for giving these antivirals, particularly molnupiravir. There has been a trial come out of America which suggests that in the first 5 days, if you give remdesivir 3 days, 3-day course, then that also involves. We are not really using it because we've got molnupiravir, but that's an option if people don't want to use molnupiravir. But it means hospitalization, so we haven't really been using that. Paxlovid is not available here. When it comes, I think as far as I'm aware, that all at-risk patients will get it. Not because it doesn't work in other patients, but because it will be limited in number. So it is almost twice as effective as molnupiravir. As far as data goes now, I haven't used it. It's not yet coming to India. I've been told it will be at least March before we can see it in India. By that time, it will probably be Omega.
By steam inhalation and gargling, saline gargle. Dr. Pialishan Chatterjee, I think you answered part of it already. Special emphasis to immunocompromised patient. You told them that currently.
Yes, absolutely. All the immunocompromised patients whom we are checking COVID antibodies after, even 2 doses of, a lot of them are having low antibodies. So they would be very vulnerable to severe disease. And I would strongly recommend that they get it.
OnePlus Note 2 5G hasn't said his name. My wife and 9-month-old child are RAT positive and home isolated, but my child is RAT positive 33 days prior. How many days will they remain in home isolation? I will answer it on behalf of Shumida. Is from the day of the symptoms for 7 days, or if they are asymptomatic from the date of the test, provided they are aparixial for the last 3 days, it should be 7 days. And you do not do a repeat test. They will be presumed not infective anymore. They will end your home isolation. I think I'm correct. There is a controversy in the West Bengal. It is still 17 days. Our Omicron figures are 20 days, and our home isolation figure in West Bengal is still 17 days. The world has gone from 21 days to 17 days to 10 days, and now 7 days, including India. But is it right, Kaushik Chaki? We are still 17 days.
Yes,
I
as
don't
per
know. We are
the
using 7.
Sumita, carry on, please.
We are using 7 days. It's a very interesting question because it also relates on debunking a little myth which has come up. There's a myth that Omicron CT values on RT-PCR is much lower, and that's how you make out it's Omicron. That is nonsense. It's absolute nonsense. They have tried out. If anybody's interested, they can message me. I'll give them the article. There is no difference between Delta and Omicron in CT values. If you calculate the day, what CT values tell you is how many days since the infection. From day 1, it's about 16. Day 2, it's about 18. Then 20, 22, 25, 27. End of 1 week, it's just about near about 30. So this thing about CT value is got everything to do with date of onset and nothing to do with the variant. And trying to diagnose Omicron because this is so is nonsense. Is nonsense. And therefore, what is happening in Omicron is that by day 7 with Delta as well as Omicron, there's a less than 5% chance that you are infective. You may be RT-PCR positive, but and rat tests are being used as a surrogate for infectivity, particularly in the UK. They are saying you can join on 7th if the 6th and 7th day rat, you can join on the 8th day if the 6th and 7th day rat is negative. So that seems to be a very reasonable thing to me. But again, on an average, there's a very small chance at day 8 that you are infective.
That's a strange thing, Sumita. I have also heard that in USA is also hovering towards rat test more. Is it again a financial decision or a clinical decision?
No. See, the thing is they are risk managing. So at day 7, there will be 5% people who are not very symptomatic, who are still infectious, not RT-PCR positive, infectious, less than 5%. Now, that is acceptable in a pandemic because of the healthcare crisis for them to come in. To mitigate against this, they are asking for 2 rats on 6th and 7th day. So if they are negative, that's 95% probability they are not infectious. So both together, less than 1% probability of infectiousness. So that is the UK. I think it's the most sensible thing. But as it would in UK, they have run out of rat tests, so they're just following the 7-day rule.
We are as well. It's not available in the pharmacies anymore. They have just exhausted.
Yeah.
Shankarnath Jha is again asked, in second wave, we saw HSCT thorax being done in every patient reaching ER. Is it needed?
It wasn't needed then, it isn't needed now. Again, I've just had a patient I was discussing about an hour ago. He was hypoxic day 1 of fever and Omicron, COVID positive. So I asked for actually CTP and they did an HRCT because he was hypoxic, and one day you don't get hypoxic in COVID. So I felt that we needed to rule out other things. So we've asked for another CTPA. So it's the clinical necessity. For COVID diagnosis, it is not necessary. If you have a negative RT-PCR and you still think it's COVID, only then you should do an HRCT. Or it's about other diseases. You think there's unilateral crackles, it could be pneumonia, you do an HRCT. If you think it's heart failure, you do an HRCT. Is it COVID? Is it heart failure? What's going on? That sort of thing. So it needs to be individualized. This routine HRCTs we discouraged and we tried to avoid as far as possible.
Professor Pranab Kumar Bhattacharya has said that persistent dry cough for more than 7 days in home isolation, steroid inhalers is indicated and helpful. I think we can agree to that. The Budicort, especially 800 microgram, isn't it?
There is no scientific evidence to that. The reason for steroid inhalers, I am prescribing steroid inhalers in a lot of people because it has been shown in 2 small studies to have decreased the chance of severe disease. However, the symptomatic benefit is still unclear. So I wouldn't mind if you gave that, but really not a very strong recommendation.
Kaushik Chaki is asked that if a patient on a post-exposure rabies vaccination, can he take COVID vaccine before completing the entire anti-rabies vaccine?
I wouldn't. I don't think there is any scientific basis to be worried about Covaxin. They are actually given flu shots and COVID vaccines in 2 different arms in the UK. So there is no reason to suspect that one.
They have also said that. You can take it at the same time, actually.
Yes, yes. And it might actually make things better. The immunity will be more stimulated. So I would say, yes, just go for it. Both are serious diseases and you don't need to stop one for the other.
Okay, guys, we are running out of time. Last few questions. Dolan Chapadas Gupta, aged 15 to 18 are now taking vaccine. If they get infected right now, for how long they will wait for vaccination?
1 month.
1 month. And that's a clinical answer. Don't wait for the government thing. It's different.
Yeah, what I'm telling people is to just not mention that they've had COVID. Just 1 month. That's it.
Redmi has asked the same question again. I think we have discussed it twice or thrice already. Patient on immunosuppressive treatment for cancer, organ recipient, what should be done if mild symptoms now?
You treat with molnupiravir in the first 5 days.
Okay. All right. Okay. Dr. Pranab Kumar Bhattacharya has reiterated that. Saurabh Mukherjee, management protocol for infants with COVID positive. Shumita, you want to take this question?
Now, this is a googly. I don't see children at all. I don't think they need management. Basically,
absolutely. That's what the pediatricians are saying. They don't
they
really
get a stuffy
management.
nose and a common cold, and they need some tender loving care. That's all.
That's all.
Arjun, Dr. Arun Mangalik sir is there as a pediatrician. If he's there, and unmute himself, he can answer the question.
Dr. Arun Mangalik, can you answer this question, please? Hello?
He has to unmute himself.
Please unmute yourself. Dr. Arun Mangalik, can you hear us? Hello?
Okay. He can answer when he is ready, but you can take the last few questions.
Okay. Government vaccination
still got 5 minutes to go.
Sure. Dr. Niladri Dingal is saying that government vaccination center are asking to take a second dose after 4 weeks in 15 to 18 age group. So
I didn't get that. What is the
government vaccination centers are asking to take for children 15 to 18, the second dose is after 4 weeks, not 3 months or 6 months.
Actually, the government.
No, that is Covaxin. That is Covaxin.
Covaxin.
So that is Covaxin is standard 4 weeks. That's why they're saying that.
That's okay.
So children are not getting Covishield at all. So that is the reason they're giving the 4 weeks thing.
Okay,
it's not a bad idea because we need them to be immune as fast as possible.
Absolutely. Kanchan Mukherjee is being cheeky again. Given a choice, should one have a Covaxin booster having had 2 doses of Covishield, or should we have the same type? I mean, same type. Shumita has said that we are the only country who are using the same type for 3 vaccines. So, and the data is unavailable, so we don't know. Any vaccine is probably better than no vaccine. But Shumita, is Covaxin 2-dose Covishield and then 1 Covaxin?
I don't know. Let's be honest. We don't have enough data to compare. What is clear is that 2 doses of Covaxin is inferior to 2 doses of Covishield.
Keep it that way, but the numbers are going to go up and up for the next few days. And some of them are going to get very sick and going to get admitted. We really don't know. We have done our bit. We have gone to the court. We have sent warnings from us, West Bengal Doctors Forum, from Joint Platform of Doctors. We have all given warnings. If people and the government doesn't heed it, then there's not much we can do. We don't set the guidelines, or we are not the decision makers. We don't write the checks. Thank you very much. Thank you.
Arjun,
it was a brilliant.
Arjun, I'll just end by thanking you and Shumita very much, and everybody who joined. More than 100 people have joined. Some people could not join due to some technical reasons. So we have recorded the whole program, and we will upload it into our the WBDF YouTube channel and as
And
well
we'll
as
share.
the WBDF group and to everybody. Thank you very much.
Thank you. Thank you. Bye-bye.